Cranial nerves and their nuclei, chapter 12. So this is a pretty hefty PowerPoint and a lot of really good information that's really vital for understanding a lot of things that we do in neurology. So make sure you take the time with this one and make sure that you understand the cranial nerves, their functions, and where they are and what's going on. Let's get started. These are your resources. I took it from a bunch of different resources. Okay, so go ahead and take out a piece of paper and write out your cranial nerves. So the names, functions, and if they're sensory, motor, or both. So go ahead and pause this, see if you can do it. Check in on your long-term memory of the cranial nerves, and then when you're done, unpause and come on back. Okay, how did you do? So here are cranial nerves, 1 through 12. And then the names: olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibular cochlear, glossopharyngeal, vagus, accessory, and hypoglossal. And then you can see the different functions there as well. And then the type: some say marry money, but my brother says big brains matter more. Sensory, motor, or both sensory and motor. We look at the rules of fours. This is a really nice way to understand the brainstem, to understand where the cranial nerves are, and to what we call locate the lesion. So if there's a stroke somewhere or something's going on in the brainstem area, we can figure out where it is by their symptoms. So always kind of flip back to this. So we go 1 through 12 are cranial nerves. Well, let's go through here. Rule 4 is 4 structures in the midline that begin with M. Number 2, 4 motor nuclei in the midline that are divisors of 12. So 3, 4, 6, and 12. So we kind of ignore 2. Okay? So 1 and 2 are up, not in the midbrain area or below. 4 structures to the side meaning lateral here, that start with S. And then 4 cranial nerves in the medulla, 4 in the pons, and 4 in the midbrain and above. So remember 1 and 2, not in midbrain, they're above. So that rule number 1, 4 medial structures that start with M are motor pathways, medial lemniscus, that's spelled wrong, lemniscus, and medial longitudinal fasciculus, and our motor nucleus and nerve. Here's a nice picture of it for you, so you can look at the M's in the middle there. So see this little kind of dentate area? This is the inferior olive here. This is how we know that we're in the medulla if it didn't tell us that we're in the medulla. And then you can see the different S structures here that we'll look at in a second, off to the side or lateral. And then you can see the different, where are we here? Let's check it out. There you go. Rule 2, 4 medial motor nucleus. So 1, cranial nerve divides the number 12. Cranial nerves 3, 4, 6, and 12 are midline. Cranial nerves, or nuclei, 3, 4, 6, and 12 are midline. So nuclei and nerves. And then 5, 7, 9, and 11 are lateral or off to the side. Rule 3, those side structures, 4 side structures: spinocerebellar pathway, spinothalamic pathway, sensory nucleus of trigeminal, and sympathetic pathway, all off to the side or lateral. So you can see these S's over here, off to the side or lateral. And then our cranial nerve. So why we're talking about this in our cranial nerve PowerPoint. So you write out your 1 through 12 cranial nerves, and then you just put a little line at see 12, 11, 10, 9, so there's 4, right? So count out another 4, put another line, and then we go medulla, pons, midbrain, and above. So now we know that when we see symptoms of one of these cranial nerves not working appropriately, we can probably locate that lesion to that area. So what that means is we're going to be looking at things in like a latitude and a longitude concept. So that longitude concept, medulla, pons, midbrain, we use the cranial nerves to tell us that aspect. Latitude is going to be that medial and the side, or the lateral aspect, the M and the S. The four medial M structures and their associated deficits. So they're deficits here. Motor pathway or cortical spinal tract is what they're talking about when we talk about the motor pathway. It's contralateral, so it crosses over, remember. Contralateral weakness of the arm and leg. So if cortical spinal tract is affected, you're going to see the contralateral arm and leg not working. Classic stroke symptoms. Medial lemniscus. So remember, medial lemniscus is going to be spinothalamic and dorsal columns. So medial lemniscus, contralateral loss of vibration and proprioception of the arm and leg. Medial longitudinal fasciculus. So this is the ipsilateral internuclear ophthalmoplegia. So some of us might not have gotten to that ophthalmoplegia yet, but that's failure of failure of adduction of the ipsilateral eye towards the nose and nystagmus in the opposite eye as it looks laterally. But MLF is really just going to be our conjugate gaze. So the yoked ability of both eyes to move appropriately in the right direction as expected is facilitated by the medial longitudinal fasciculus. So it really connects those functions together. Number 4, the motor nucleus and nerve. Ipsilateral loss, same side. Loss of the cranial nerve that's affected. So we're going to see 3, 4, 6, or 12, ipsilateral. So cranial nerves, ipsilateral, and then the motor pathway corticospinal, contralateral. 4 structures to this side beginning with S, deficits. What if there's a problem here? So we'll see spinocerebellar pathways. That problem will manifest as ipsilateral ataxia of the arm and leg. 2, spinothalamic pathway, contralateral alteration of pain and temperature affecting the arm, leg, rarely the trunk. 3, the sensory nucleus of the 5th, so our ipsilateral alteration of pain and temperature on the face, okay, so trigeminal, and the distribution of the 5th cranial nerve, so trigeminal. This nucleus is a long vertical structure that extends in the lateral aspect of the pons down into the medulla, and we'll look at that trigeminal tract in a little bit here when we get into our cranial nerves. The sympathetic pathway, so ipsilateral Horner's syndrome, that is partial ptosis and a small pupil. So we're going to see a small pupil or a constricted pupil. We're going to see ptosis and we're going to see anhidrosis. So anhidrosis is a lack of sweating. So the mnemonic is PAM, P-A-M as in Mary, ptosis with a P, anhidrosis, and then meiosis, so the small pupil. So that's Horner's syndrome, PAM Horner. 4 cranial nerves above the pons, so that's that midbrain and above. So olfactory and optic, not in midbrain. So ocular motor, when we see deficits in ocular motor, we're going to see impaired adduction, add in, remember. Supraduction, infraduction of the ipsilateral eye with or without a dilated pupil. The eye is turned out and slightly down. Remember, ocular motor is all others 3, right? So SO4, LR6, all others 3. So superior oblique is 4, lateral rectus is 6. Every other eye movement, including pupils, is cranial nerve 3 or ocular motor. Number 4, trochlear. Eye is unable to look down when the eye is looking in towards the nose. So we follow the finger in towards the nose, and if it is unable to complete that maneuver, that's cranial nerve 4, even though we're thinking with that medial rectus being cranial nerve 3, and I put in some resources on your Brightspace that help you understand that, so specifically called SO4 or superior oblique resources. So check that out in the content page if you would like to get more information on that. Cranial nerves, 4 cranial nerves in the pons. So 5 is trigeminal, so ipsilateral alteration of pain, temperature, and light touch of the face. So we think of the trigeminal tract like we think of the spinothalamic tract of the cord, but trigeminal is for the face. So face, back as far as the anterior 2/3 of the scalp and sparing the angle of the jaw. Number 6, abducens. Ipsilateral weakness of abduction, lateral movement of the eye. So abducens, abduct. 7, facial, ipsilateral facial weakness. 8, ipsilateral deafness. 9, glossopharyngeal. So ipsilateral, loss of pharyngeal sensation. Pharyngeal meaning throat, remember. 10, vagus. Vagus means wanderer, so we're going to see an ipsilateral palatal weakness because it is innervating that the palate and then wanders all the way down. So you'll see other issues as well. Number 11, spinal accessory nerve. Ipsilateral weakness of upper trap and sternocleidomastoid muscles, so the shoulder, right, and the neck. Hypoglossal, ipsilateral weakness of the tongue. So when you stick your tongue out, it's going to not be equal and it's going to move one way or the other. And we'll see pictures to help you out with that in a little bit. So thus a medial brainstem syndrome will consist of the 4 M's, and the relevant motor cranial nerve, and the lateral brainstem syndrome will consist of the 4 S's, and either 9th through 11th cranial nerve in the medulla. So we call it a medial lesion or a lateral lesion. Or the 5th, 7th, and 8th cranial nerves if in the pons. Okay. All right, so our composition of our cranial nerves, this is not the new material, so that Rule 4 was kind of new material for some of us, but it really pulls together everything quite nicely, I think. So olfactory and optic nerves, neuron cell bodies located within the special sense organs. Other nerves with sensory information, 5, 7, 9, and 10. Neuron cell bodies located in cranial sensory ganglia. So we see this sensory motor both. Cranial nerve nuclei have a generally predictable arrangement. So that's somatotropy that we talk about all the time in neurology. So our spinal nerves contain sensory and motor fibers, we know that. A given axon entering or leaving the spinal cord can be placed in one of the following 4 categories. So we're looking at somatosensory, so body sensory. Again, even though our internal organs are part of our body, just what the layperson thinks of when, if I were to ask you to draw a body, what would you draw? That's the soma. Okay? So that's touch, pain, temperature from the skin, muscles, and joints. So think of spinal thalamic tract that we learned in chapter 10. Visceral sensory internal organs, so sensory from the viscera, so our blood vessels, our digestive tract. This isn't very specific like our somatosensory, so most of the time we only feel distension, so think about like gas pains or bloating, stuff like that is what we normally feel from the viscera. Visceral motor, so how do we move our organs? How do our organs move and glands secrete things? So think about the preganglionic autonomic axons. Number 4, somatomotor, so muscle movers or the axons of our alpha and gamma motor neurons. So modalities carried out by our cranial nerve. So we have a bunch of categories here that at first might look intimidating, but we're going to break it down. So we just take a breath and go, okay, what is it trying to tell us? General, that's pretty easy to understand, versus special, right? Easy. So that's the first word. So it's either going to be general or special. Okay, so general somatic, we already know somatic, so that's body versus general visceral. Okay, cool. Okay, so body versus internal organs. Afferent, that's sensory, okay, or ascending information. Got it. So general somatic afferent is general body sensory. That's our touch, pain, temperature, proprioception, or the position sense, remember, from our skin, muscle, or joint. Then we've got our general visceral afferent, so that's just internal organ. And then we have our special somatic afferents and special visceral afferents. So special somatic afferent, that's sensory information from our eye, our ear. So this is vision, hearing, and balance. So it's special. Okay, so our special senses. Special visceral afferent, so information from olfaction, so smell and taste, gustatory. General somatic efferent. The difference here is the efferent. We know efferent is for motor. So this is to our skeletal muscles so we can move. Visceral, so our internal organs can do their function. So smooth muscle control, heart muscle, glandular secretions. So this is referring to parasympathetic control here. Special visceral efferent to muscles derived from our branchial or pharyngeal arches. So we'll look at those pharyngeal arches again. All right, so we're going to see these pictures of the cranial nerve nuclei, so check out where they are. Okay, so if you're looking at that picture on the left, so sensory roots of the cranial nerves coming in, we can see that sulcus limitans, which is separating sensory from motor. And then we can see somatomotor, visceral sensory, and somatosensory. And then I highlighted in pink over here the sulcus limitans, where it is when we're looking at this view. So you could see the fourth ventricle here, you could see the fourth ventricle here. Categories of our nerve fibers. So structures innervated in the cranial nerve. So sensory, somatic, skin, muscle, joints of the head is going to be by trigeminal or cranial nerve 5. Sensory viscera, cranial, thoracic, abdominal viscera, taste buds, 7, 9, and 10. So remember 7 and 9, 7 is going to be sweet, and then 9 is going to be bitter, and 10 is vagus nerve, so that's going to be in the back area as well. So that makes sense that that would be visceral. Special motor, soma, extraocular muscles, so the eye muscles that we talk about. So the SO4, LR6, all others 3, so there's 3, 4, and 6. And then tongue muscles as well, so 12. Visceral, parasympathetic ganglia for cranial, thoracic, and abdominal viscera. It's got to be cranial nerve 10, so what else would go all the way down there? Pharyngeal, jaw muscles, facial muscles, laryngeal and pharyngeal muscles, middle ear muscles, SCM, and trap. And there is trigeminal, okay, so 5, 7, 10, and 11. So let's talk a little bit about embryology, or the study of embryo or in utero. How were we formed in the first place? So we looked on the last slide about the pharyngeal arches. So pharynx generally means throat, remember. So we're looking here at a picture on the right of in developmental stage here. So we can see that second pharyngeal groove, the third pharyngeal arch. We can see the cervical sinus, the second pharyngeal, or the hyoid arch. So remember, the hyoid is that tiny bone in the front of the neck. Kind of looks like a primitive mandible to me when I see it. And then when you look over here to the left, you can see the pharyngeal pouch, okay, endodermal epithelium. You can see the laryngeal orifice at the bottom, that hole there. So just understanding that this is part of developmental stages is what they're talking about. And this is a little bit more specific here. So let's get into this. So pharyngeal arches can also be known as branchial arches. You might see it called that as well. Folds in the cervical region due to flexion. So this is that neck flexure. So it resembles gill slits, so very primitive, okay? But we grow out of it. Spaces in between the arches are called pouches, and each fold has a nerve, cartilage, bone, and muscle. So think of this when we think of our innervation, specifically of our cranial nerves, but of our face, and this kind of dermatomal mapping. And you can see the pharyngeal arches over there, the trigeminal, facial, glossopharyngeal, and vagus. So branchial or pharyngeal arch number 1. So note here the M is bolded and larger here, capitalized for trigeminal. So cranial nerve 5, trigeminal arch number 1 here. So muscles of mastication or chewing, there's the M. And then Meckel's cartilage with an M. So that's our mandible, our incus, and our malleolus. Branchial arch 2, this is cranial nerve 7. So muscles of smiling, so this is our S's for 7. Smiling, stapedius, stapes, the lesser or smaller horn of the hyoid bone, all from 7. Note the S's. Cranial nerve 9 is going to be stylopharyngeus muscle and the greater horn of the hyoid and the body as well. Branchial or pharyngeal arch number 4, so cranial nerve 10, so we see the muscles of the palate and the pharynx, thyroid cartilage and cricoid cartilage. We skip 5. 5 is rudimentary and has no derivatives according to the literature. So we go into arch 6, cranial nerve 10 or vagus. So this is going to be the muscles of the larynx. Remember, that's the voice box. So we're going to see laryngeal cartilage. And here's that same picture, give you kind of an idea of what we're looking at. Feel free to pause on any of these pictures and check it out if you want. So brainstem here. So things we want to make sure that we memorize here. We saw that sulcus limitans a little bit earlier. So the motor nuclei will be medial to the sulcus limitans, sensory will be lateral. Motor, medial. Remember that is part of our rule of fours. M, motor, M, medial. Sensory is lateral to the sulcus limitans, or that rule of fours talks about it being to the side. Okay. Alar, sensory, lateral, okay, or side. Basal, motor, medial. So make sure we understand that language. So the alar is sensory, and that's off to the side. And then basal is motor, and that's medial. So this is kind of a confusing picture here on the left. So I found a couple more resources to try and make it a little bit easier to look at and understand. And at first, they look complex anyways. So it's just a matter of time hanging out with it and looking at it. And once I started to look at it with the idea of the spinal cord tracts, where it's kind of analogous to the tracts here, it started to make a little bit more sense. So when we look here, if you look up top, we can see this picture on the right. I'm going to grab my pen here for you. So we could see these bumps here, right? So on both sides, okay, you guessed it, that's superior colliculus, and then below that is obviously inferior colliculus. So superior colliculus, remember, is our visual reflex. So we see something out of the corner of our eye, we turn and look. That's superior colliculus that is in charge of that reflex. Inferior colliculus is we hear something out of the ordinary and we turn and look. Remember that for both of them, we end up turning and looking. Okay, but it's the stimulus that tells us which the right answer is. And then if you look here, here is our good old Edinger-Westphal, and it is that spot right there. And then we can see oculomotor nucleus here as well. So that makes sense that that would be up by superior colliculus, because that has to do with eyes, eye movement, and pupil. And then if I can direct your attention here to this yellow tract, if you will, that's the principal trigeminal nucleus. So trigeminal is a major tract, major pathway, and it's not just the trigeminal nerve that uses that pathway. Okay, so think of it more like a tract. So I think of it kind of like spinal thalamic is for the body, trigeminal is for the face, so touch, pain, temperature of the face. And then we can see the vestibular nuclei right next to it here. Okay, so where are we in space? What's our balance? And then cochlear, right? So we have vestibulocochlear nerve that is combined basically, and then we have our cochlear nuclei right next to it. So that makes sense. And then we're going to talk more about the solitary tract. It's not just one thing, so it's kind of a misnomer. And then our hypoglossal nucleus, spinal trigeminal here as well. So going into the spinal area. So why does a good upper cervical adjustment help with trigeminal neuralgia? It's because the trigeminal tract goes all the way down into the cervical spine. Accessory nucleus, so think of cranial nerve 11, so that is, again, SCM and upper traps. Nucleus ambiguus is going to be 9 and 10. Sometimes you'll see it as 11 as well, but ambiguous 9 and 10. Dorsal motor nucleus of vagus. Vagus is 10, remember, and internal organs. Salivatory, so saliva. Facial, abducens, trigeminal motor. Okay, so chewing, trigeminal motor. Remember that M was bolded and capitalized for muscles of mastication. And then trochlear is here as well, and oculomotor is where we started. This chart puts it all together. So we can look here, cranial nerves 1 through 12 on the left. We can see the names. We can see are they sensory, motor, or both. And it's some say marry money, but my brother says big brains matter more. Let's see here. Major functions here on the next part, and then location of cells whose axons form the nerve. So this is the cell bodies. Okay? This is a way of just saying the nucleus. Okay, so that's the nucleus, so that collection of cell bodies. So where are they? So cranial nerve 1, nasal epithelium. Cranial nerve 2, retina. Cranial nerve 3, oculomotor nerve, oculomotor nucleus in the midbrain. That's that Edinger-Westphal nucleus as well is there. So we saw that up top by superior colliculus in the last slide. Trochlear nucleus in the midbrain, trochlear nerve. Cranial nerve 5, trigeminal nerve, trigeminal motor nucleus in the pons. trigeminal sensory ganglia, the Gasserian ganglion, abducens nucleus for abducens nerve, and then facial nerve, facial motor nucleus, also superior salivatory nuclei in the pons and geniculate ganglion. And geniculate we associate with taste. Okay? So superior salivatory nucleus. So remember that facial nerve is going to be the anterior 2/3 of the tongue. So we think of it as sweet, but it's also salty, sour, everything basically but bitter, because bitter is 9 in the back, and then 7 is everything else. But those S's, salty, sweet, sour, and so it would make sense that that would create a salivation as well. Okay, so you start eating something, and we need our saliva to kick in. Cranial nerve 8, vestibular cochlear. So this is, you want to associate this one with the spiral ganglion or the vestibular ganglion. It used to be called the scarpas. Okay, so spiral and vestibular. So vestibular cochlear. 9 is going to have that nucleus ambiguus, remember? So 9 and 10. So I remember that just by the mnemonic ANT, ant. Ambiguous for the A. 9 starts with an N, like N-I-N-E. And then 10, T-E-N. So A-N-T, nucleus ambiguus. Ambiguous, 9, 10 is how I memorized that. If that helps you, cool. If not, it's, you know, just little tricks. 10 here. Dorsal motor nucleus of vagus, nucleus ambiguus again, and vagal motor or vagal nerve ganglion. 11, spinal accessory. So we know this is going to control SCM and upper trap, so it makes sense that it's in the superior cervical cord or in the neck. Hypoglossal nerve, hypoglossal nucleus in the medulla. So remember where these are by your rule of 4. So I'll take my red marker here and remind you, we just count up 1, 2, 3, 4. I'm over there on the left, and we draw a line here, and then 1, 2, 3, 4. Draw a line here, and then we know that this is medulla, this is pons, this is midbrain, and above, because 1 and 2 are not in midbrain, remember. Okay, so instead of trying to memorize over here on the right, looking here going, okay, so this is in the pons, right? And trying to memorize them all individually without an organization. Just do your divisor there and then medulla, pons, midbrain. That's why we drill in the information of medulla, pons, midbrain over and over again in quarter 2. Here's that nucleus ambiguous 9 and 10. So what's it for? Speech, swallowing, and also the heart. Okay, so also the heart because that's vagus. Nucleus solitarius, see, not solitary, not just one. It is 7, 9, and 10. 7, 9, and 10. So lower brainstem regulation of visceral, cardiovascular, and respiratory. So internal organ, heart and blood vessels, and respiratory. Major coordinator of autonomic nervous system. So remember, our autonomics are going to be our fight or flight and our rest and digest. The autonomic nervous system regulation of cardiovascular, respiratory, gustatory, so taste, GI, gastrointestinal, and chemoreceptive aspects of homeostasis, or our balance of the chemistry of our body. Solitary nucleus is also notable for large numbers of neurotransmitters, which is the chemistry of how our nerves work, which are found therein. So it coordinates endocrine or hormonal responses to internal bodily stresses. So think about that autonomic nervous system again. So these 16 cranial nerve nuclei can be most easily remembered if they're assembled into functional groups in anatomical location. So remember, we're going to use these with that rule of 4s in order to localize the lesion. So this gives us that idea of where is the lesion. Is it medulla, pons, or midbrain? So that's how we're going to be able to figure out where to do our neuro rehab. So 3 of the groups of motor nuclei, a somatomotor group, a branchial motor group, and a visceral motor or parasympathetic pregang group. The other 3 groups are sensory, so it's general sensory, special sensory, and visceral sensory. So this chart is in your book. It's not as colorful in the book, but it is medulla, pons, midbrain, and where the nucleus or the nuclei are. Okay? So if this helps you kind of coordinate where the nuclei are, great. I put this in here so you could rewrite that, because I always like to rewrite things when I'm studying them. That's just a study tip, a study tool there for you. 7, 9, 10 have 5 components. So most of the cranial nerves are connected to only 1 or 2 cranial nerve nuclei. So only 3 nerves carry components from more than 2 nuclei. So what's going on here? So these nerves 7, 9, and 10 carry 5 components, 7, 9, and 10. So it's branchial, parasympathetics, which is your rest and digest, somatosensory, so body, special visceral, so taste, 7 and 9, remember our taste. 10 has a taste component to it as well, slight. General visceral sensory component, so internal organ sensory, and these 3 nerves lack a somatomotor component. Here's that picture again, just a little bit bigger, just to kind of remind you of the pathways here. It's actually a different picture. You can tell that it's different colors. So I grabbed this from a neuroscience book here. You can see the reference on the left here. So you can also see the slices here kind of telling you where you are in space all the way down. So it's just transverse slices of this. So it gives you just another viewpoint of that, and you can see the somatomotor, branchial motor, visceral motor, this chart here for the color key there to kind of help you. So this is just explaining the pictures, the schematic overview of how the nuclei are arranged, and it points out these 3 things. So number 1, the cranial nerve nuclei lie in the tegmentum of the brainstem. So remember, tegmentum versus tectum. Tectum is in the back, and tegmentum is going to be more anterior of the brain in comparison to the tectum of the brainstem, as do many of the major ascending and descending tracts. So what's going up, what's going down, right? So just number 2, just as in the spinal cord, the nuclei that receive sensory inputs via cranial nerves are spatially separate from those that give rise to motor output with the sensory nuclei located laterally and motor medially. So this is just one of those rules of 4. So sensory side, motor medial. Number 3, the cranial nerve nuclei that serve comparable functions are aligned in the longitudinal axis. So remember our latitude and longitude, this is that localization of the lesions here. Even when their comparable nuclei, like somatomotor nuclei, are distributed across brainstem subdivisions, the spatial segregation of sensory and motor function provides the important clue for that localization of the lesion or of a focal damage in the brainstem. So think like a stroke or some sort of maybe multiple sclerosis plaque or some sort of damage into that area. Thus, an understanding of the functions and locations of cranial nerve nuclei is essential for diagnosing and treating neurological injury, dysfunction, disease, and then plays an important role in our neuro rehab for our patients. Cranial nerves 3, 4, 6, 11, and 12 contain somatomotor fibers, so it's going to move. Okay, so movement. Simplest of the cranial nerves because each contain only 1 category, except for 3 has some preganglionic parasympathetic fibers. So remember, 3 is the all others 3, including pupils. Nuclei of origin of these nerves are located adjacent to the midline near the cerebral aqueduct. So the cerebral aqueduct, remember, is going to be connecting third ventricle. I'm going to highlight it right here in, well, let's go in green here. So it is 3rd ventricle to 4th ventricle. So this line right here is the cerebral aqueduct. So up into this area is 3. And then you could see the 4th ventricle. I just circled it there for you. So again, I'll highlight it in red. The cerebral aqueduct is right here. Okay, so superior colliculus, inferior colliculus are in this area here. Okay. Cerebral aqueduct, again, highlighted here for you. You could see it highlighted in both pictures. Inflammation, cerebral aqueduct, 4th ventricle, cranial nerves 3, 4, and 6. What's going on here? This is key to understanding neuro rehab and why we do eye movements and causes of the inflammatory response here in the brain. When we're checking in on our nerve health, on our brain health, we say the eyes are the window to the soul out in the world, right? So in neuro, we say eyes are the windows to the brain because this guy on the left, he gets hit in the head as a big football tackle here. And after they check out and make sure that he is AO times 3, meaning alert and oriented times 3, meaning do you know who you are, where you are, and what year is it? After they figure that out, they'll check his eye movements out, as Justin Timberlake to the right is demonstrating for us. So you would do that H pattern and say, hey, follow my finger. And if they can't follow your finger appropriately, or if we see some nystagmus or some improper movements in there, we know that that cerebral aqueduct is inflamed. The rest of the brain, we can assume, might be inflamed as well. And we know to get this guy some help. This slide points out that it's not always just trauma, physical trauma like the football player getting hit that can cause these problems, but inflammation, neuroinflammation is what we call it, but it's an inflammatory response all throughout the body. And where does inflammation come from? What's the biggest driver of inflammation in our society today? I would say, and a lot of people would say, and I learned it from this guy, that it's food. So it's the food that we eat that is inflammatory. This work is done by Dr. David Seaman. He is a chiropractor. He used to teach here. He used to be my teacher. He also teaches in the Neurology Diplomate program. His work is cited by Harvard Med. He's got a lot of published papers. He's got a diplomate, a double diplomate actually, one in neurology, one in nutrition. So when this guy talks, I listen, basically, is what I'm trying to tell you. His website is dflame.com. And over to the right there is a schematic that he talks about. It's basically saying that if we don't get proper B vitamins, our body is set up to kind of steal the foundational, like, building blocks of those B vitamins from the serotonin cycle. So if we don't have enough B vitamins, we're going to steal from the serotonin cycle, and we won't have enough serotonin or proper serotonin in the right places, and then melatonin. So sleep-wake cycles, happy awake and alert cycle, the idea of why are so many people on SSRIs, selective serotonin reuptake inhibitors. So as a part of my foundation for me as a person, I take methylated B vitamins. I also recommended them to pretty much every single patient that I had. I can't even think of a reason why they wouldn't take that. B vitamins are water soluble, and the methylated vitamins are the format that you want. So it's always a good idea, especially if they're having nerve issues or serotonin or really just anxiety, depression, things like that. And this is the chemistry behind it. I'm not going to go into it. I'm not going to test you on it. It's upper level educational information for you that's available in the Neurology Diplomate program. And he basically went through this and the rest of his paper here in about, I think it was like a 10-hour class. So the weekend's 15 hours, but the 10-hour class. But boil it down and know that it's thoughts, traumas, and toxins. Those toxins are explained through chemistry. Here are the eye muscles. Okay, so you can see that superior oblique is up here, which is weird on why it would do looking at the nose, right? So we can see the ocular motor nucleus over here, okay, in blue, and you can see that going into the eye muscles. Okay, so ocular motor, cranial nerve 3, so all others 3. So LR6, SO4, LR6, AO3, all others are cranial nerve 3, including pupil. So we could see this is the 6th cranial nerve here for lateral rectus. Where are we here? We're going into medulla. The circular shape here is the pons. Over here is the cerebellum. And this right here is the 4th ventricle. Here is the cerebral aqueduct. Superior colliculus, inferior colliculus are over here. Okay, that's where we are. You could see cranial nerve 3, superior rectus, medial rectus, inferior oblique. And then another picture on the right here to give you a little more context. I really like this picture. It tells us where the cranial nerves are and how they converge at the ear. I find this particularly useful in trying to explain auricular acupuncture and why we needle the ear and get so many great results just from needling the ear. So you can see in that upper gray kind of slate color, that's telling us that the trigeminal nerve, or touch pain temperature of the face, right? So trigeminal nerve is going to be that aspect of the ear, and auricular temporal nerve, so auricular ear, temporal, temple, right? Temporal area. And then if you look at the pink, that's the vagus nerve and glossopharyngeal nerve, so in the center pink area there. So super interesting when we look at where different acupuncture points are. Facial nerve is the purple dots kind of superimposed over that entire area. So it's not just those dots, but it's just letting you know that it's everywhere. Okay, facial nerve, 7. And then the other kind of peachy color there is the cervical plexus, so neck. Remember, cervical plexus, lesser occipital nerves, occipital, right? And greater auricular, and then facial nerve again superimposed over that as well. So kind of interesting stuff here. Sensory innervation of the auricle, so that ear, okay, so the main ear part that we think of. Auricular region as complex nerve supply because developmentally it's located at the boundary between cranial nerves, pharyngeal arch nerves, and the branches of the cervical plexus. So we see 4 cranial nerves contributing to the innervation of the auricle. So we saw trigeminal. We saw facial, so the skin area that receives sensory innervation from facial nerve, not precisely known. Glossopharyngeal, vagus, 2 branches of the cervical plexus, being C2, C2, C3. So when we adjust C2 area, C3, so when we adjust this area, we are affecting the ear. So if somebody has an earache, this is one of the things that we think of is to adjust C2. Among other reasons for it, think the eustachian tube and drainage, things like that, but this is one of the reasons why this is helpful to do what we do as chiropractors. This is the same author picture, so continuing what this looks like, but from the posterior aspect. You could see trigeminal or cranial nerve 5, again in that slate color on the upper part of the ear. And then we can see vagus and glossopharyngeal as the pink area there. And then we can see facial nerve, the little purple dots superimposed over the entire area, including cervical plexus, being the lesser occipital and greater auricular nerve. So kind of interesting here, I thought. Note, because the vagus nerve contributes to the innervation of the external auditory canal, so the ear canal, auricular branch, so see that picture that we were looking at. Mechanical cleaning of the ear canal, or when you examine the ear with an otoscope, you can evoke coughing, nausea, or kind of give them the shivers. The auricular branch of this vagus nerve passes through this mastoid canaliculus, which is small canal, and through a space between the mastoid process and the tympanic part of the temporal bone, being the tympanomastoid fissure being a crack, remember, or deep groove, to the external ear and external auditory canal. So the ear canal receives sensory fibers from the glossopharyngeal nerve through its communicating branch with the vagus nerve. So just a little explanation of that. And then I wanted to show you typical acupuncture treatment for anxiety on the left there. So I just snagged this picture off of the internet. It's just a basic auricular treatment for anxiety. So we look at some of those words there. It might look interesting at the top left, Shen Men. We'll look at that in a minute. So it's basically just like spirit. Point 0, heart, occiput, master cerebral or nervousness point, tranquilizer point, adrenal gland, vagus nerve, and sympathetic autonomic point. And you can kind of see where those would correlate to what we know on the right for our nervous system. So just kind of an interesting note here how the points correlate. So let's look at that with something called the NADA protocol. This is a common thing. So you see those advertisements out there for quit smoking with acupuncture. They're probably going to use the NADA protocol for part of their smoking cessation program. They're 5 points. Okay? They're selected for acupuncturists as an adjunct to comprehensive addiction treatment for programs. Shen Men, there's that Shen Men again, we'll look at that. Autonomic liver, lung, and kidney points. Okay, so looking at that Shen Men, some common uses of this point include for treating anxiety, stress, depression, insomnia, pain, addiction, and detoxification. Some practitioners are going to call Shen Men the most calming and relaxing ear point and is used with all ear point treatments. I'd like to point out how that correlates to the cranial nerves. So activating or stimulating the cranial nerves are going to have a stress reduction capacity. We just have a different language to explain it. So when we do see some neuro rehab techniques for anxiety and such, you'll see ear stimulators, like little clips with electrical current running through there. They also do tongue stimulators with a little electrical current that way, but please don't do these things at home untrained. Okay? They could have bad consequences. But we're all doing very similar stuff. It's just we have a different language to explain it. Theirs happens to be quite poetic, in my opinion. I snagged this slide from a class that I teach on auricular acupuncture and explaining the neuro behind it. So auricular acupuncture at the Shen Men and 0.0 points induced parasympathetic activation. If you note, that is taken from a NIH PubMed peer-reviewed journal, so it's the research is there. Data indicates that occlusion press needles at Shen Men and 0.0 points at both auricles increase that parasympathetic nerve activity. So again, they're just explaining it in traditional Chinese medicine terms, but we can also explain it in neurological Western anatomy terms for cranial nerve stimulation with the press needles. Those are little tiny little ear seeds. You might have seen those before that don't have a needle on them. These have a little tiny needle on it, so it'll irritate the tissue. You cannot use these unless you are certified in acupuncture, depending on what state you're in, but you can use the seeds. You don't puncture the skin with the seeds, so that's still in the scope of practice as a chiropractor if you just use the seeds with a little tape on it. It's not gonna do anything, but to puncture the skin, you have to check out your state's requirements of what you need. Okay, so this is ending part 1 of this PowerPoint. So for time and storage space purposes, I'm stopping here. And when you get into part 2, that's when we get into the specific cranial nerves and what you need to know in detail of each specific nerve. But make sure that you know everything up until this point as well. So both of these PowerPoints go together. So I'll see you in part 2.